Hi, everyone, and thanks for this opportunity. The biggest challenge now is I'm presenting after Roger, so try not to compare. Um, I'm Adel Aref, and my project, which was recently funded by Cure Cancer, is about identifying a predictive proteomic-based signature for response to immunotherapy in patients with malignant pleural mesothelioma. A very brief introduction about myself. Sorry. So I was graduated from medical school in Shams University in Egypt 2003, which has been a long way back. Started my training in clinical oncology in 2005 and finished the training in 2008. I moved to United Arab Emirates in 2009 to work as a medical oncology specialist. I spent there around 5 years. During these 5 years, I got specialty certification in medical oncology from the Royal College of Physicians UK and from the European Society of Medical Oncology. In 2015, I moved to Kingdom of Bahrain to work as a senior medical oncologist, Salmania Medical Complex, and I started applying for PhD scholarship because I was more interested in cancer research. So I was lucky to get awarded a PhD scholarship from the University of Adelaide, South Australia, and with a top-up from the Freemason Center for Male Health Wellbeing. I moved to Adelaide in 2016. My PhD was with Professor Lisa Butler in the Lipid and Prostate Cancer Research Group in SAMRI, Adelaide. I was awarded the PhD in 2019, December 2019. In the following couple of years, I worked as a senior analyst health technology assessment at the School of Public Health in University of Adelaide. And then I moved to my current position in mid-2021 as a senior researcher at ProCan Oncology at CMRI, working with Roger. Also currently conjoint lecturer at the University of Sydney and currently enrolled in a master degree program in clinical trial methodology, University College London, UK. My research interest areas are cancer research, cancer proteomic, biomarker discovery, and clinical trial methodology. So about the project. So as you may know, malignant mesothelioma is a cancer that arises from the layers that cover the lung, which called the pleura. It's different from cancer lung, which arises from within the lung parenchyma or the lung flesh itself. Mesothelioma is mainly associated with asbestos exposure with a very long latent period between exposure and appearance of the disease, which can extend up to 20 years. Although it is a rare disease, the estimate percent of new cases in Australia is around 0.6%. It's a highly aggressive disease, and chance of surviving 5 years post-diagnosis is usually less than 7%. From this figure from Cancer Australia website, you can see that the incidence of mesothelioma has been almost tripled during the last 30 to 40 years. Interestingly, Australia is among the highest countries worldwide in terms of incidence rate of mesothelioma and death rate from mesothelioma. And this was actually a very surprising information to me. Mesothelioma has a lot of multidimensional challenges. One of them is the tumor microenvironment. So the tumor itself, or the microenvironment of the tumor, is composed mainly of immune-related cells like tumor-associated macrophages, myeloid-derived suppressor cells, CD4, CD8, and this composition actually suppresses the ability of the immune system to recognize the cancer cell and attack it. Mesothelioma is mainly classified to 4 types or big 2 subtypes. The epithelioid one, which is the least aggressive in comparison, and the sarcomatoid one, which is a highly aggressive one. And actually, one of the reasons that partially explain this differential prognosis and the difference in response to treatment, many immunotherapy, which I'll discuss later, is the difference in the microenvironment between these subtypes. For example, the non-epithelioid types have higher CD8 expression and PD-L1 expression, and this may partially explain this prognosis and response to treatment, but it adds challenge to management of mesothelioma. Unfortunately, around 60 to 70% of the patients are diagnosed at unresectable stage. And this means that the option of surgery and local radiotherapy is not working. So for the minority which are diagnosed with early resectable changes, option of treatment include either chemotherapy followed by surgery and radiotherapy, or surgery followed by a combination of chemoradiotherapy. However, for the majority of patients diagnosed with the unresectable stage, the option of treatment is conventional chemotherapy, which has been the standard of care for the last maybe 30 or 40 years, mainly with platinum-based chemotherapy. In the early 2000s, pemetrexed was introduced in the combination chemotherapy regimen, and it has improved survival and response rates a bit, but it has stayed the standard of care until very recently, maybe just 5 or 6 years back, when immunotherapy was introduced in the clinical practice. And in a very simple way, immunotherapy works by inducing the immune system in the body to recognize and attack the cancer cell and just shrink the tumor. Most recently, it has been very recently when immunotherapy was approved for management of mesothelioma. This was based on the confirmed trial, which approved nivo as a single agent immunotherapy, and then the combination based on the CheckMate study, which approved the nivo-EP combination. So despite the strong rationale behind using immunotherapy in malignant mesothelioma, it has its own challenges. First, the benefit of single-agent immunotherapy seems to be debatable and highly confounded by the trial design that introduced it. Second, the use of combination chemotherapy like nivo-EP, although it did improve overall survival, and because of which it was FDA approved recently, this was at a cost of higher toxicity, both in terms of side effect and in terms of financial toxicity. And there is a lot of debate about the cost effectiveness of combination immunotherapy in malignant mesothelioma. A pooled data from a systematic review showed that the benefit of immunotherapy in mesothelioma is mainly confounded by study design, patient selection, the histopathological types, and that the comparison between clinical trials and real-world data is not moving in the same direction. One of the biggest challenges and reason for this debate is the lack of available biomarkers to guide immunotherapy in malignant mesothelioma. For example, PD-L1 expression is a non-predictive biomarker for immunotherapy in other solid tumors, not all of them, but in some of them. However, in mesothelioma, this is not the case. There is a lot of debate about a technical method to measure PD-L1, the cutoff value, and the fact that patients with either low and high PD-L1 expression showed some benefit from the treatment. So it is not the best predictive biomarkers that can guide immunotherapy in mesothelioma. So what are we going to do? In this project, we are going to perform proteomic analysis or analysis of the tissue proteins on around 300 tumor samples from patients with advanced malignant mesothelioma at time of diagnosis. The proteomic analysis will be done at our state-of-art proteomic facility at CMRI, ProCan. And for you who doesn't know about ProCan, ProCan is the largest high-throughput academic facility dedicated to cancer research, cancer proteomic research in the world. The samples for this project will be retrieved from 2 cohorts with well-annotated clinical, pathological, and follow-up data. The first cohort is from Australia, from the Asbestos Disease Research Institute, ADRI. And the other one is from French collaboration with the French National Network for Malignant Mesothelioma, or what we call Mesobank. The aims of this project is to identify protein-based signatures that predict response to immunotherapy in patients with advanced malignant mesothelioma, to identify the biological pathways associated with immunotherapy response and resistance, and to identify possible new therapeutic targets for patients not responding to immunotherapy. So as I mentioned, all the patients enrolled in this or included in these two cohorts were treated with immunotherapy at some time point, either first line or subsequent. And we will use both cohorts to compare and cross-validate the findings to get a more robust conclusion. So why proteomics? Why not genomics or transcriptomic, which are usually used? So proteomic is a very promising and evolving field in cancer research. As you may know, most of the cell function take place through protein interactions. This includes cell growth and in cancer, tumor growth and resistance to treatment. Most of the current tests use genomics and transcriptomics to identify the genes status, a presence of mutation or alteration, whatever. However, at this level, you cannot capture the changes at the proteomic level. In other words, by analyzing the proteins itself, you will get a deeper insight on the pathways and biological pathways associated with the cancer progression and response to treatment. In addition, because of the method we have developed in ProCan over the last 5 to 7 years, our methodology can overcome some of the limitations of the current genomic and transcriptomic tests in terms of cost, long processing time, and some of the intra-observer variability. So I think there is a high chance and opportunity here to implement proteomics in cancer management. So very briefly, what is the design of the project and what are we going to do? So we have all the ethics and agreements in place to allow reception of samples from these two cohorts. And we are currently working on delivering the samples. We have developed a method to allow doing proteomic analysis on just 1 or 2 20 mic section from a fresh frozen from a FFPE block, which is compatible with the clinical workflow in regular pathology labs. We are not macro dissecting because this is not the usual practice in clinical practice, but in research, yes, but not in clinical practice. We also take immediate 4 mic scene section for H&E to compare the cancer content, tumor lymphocyte infiltration, and percent of necrosis with the proteomic data that we get from this tissue, and which will give a better insight of the proteomic data we are getting. These samples will be prepared for proteomic analysis mainly by exposing them to heat and pressure to digest them. Then this lysate or this digest will run through one or more of our mass spec instruments. And we make sure that all the samples are randomized across the different instruments or machines to avoid any bias or to avoid that one confounded factor are all run at the same time on the same machine. The output of the mass spec will be analyzed using Diane software, which is a software that uses neural network artificial intelligence to identify peptides and remove any background noise. And then based on the peptide information, we do peptide to protein roll-up and generate the final protein matrix. This protein matrix will be then used for analysis. We'll be using different normalization method, sophisticated machine learning, and data mining to answer the research questions, which is expected to lead to high impact publication and will be a foundation for further validation and integration in prospective clinical trials. By the end of this project, we will be able to build a risk score that categorized patient into high and low risk group in terms of chance of response to immunotherapy. Identify the biological pathways related to response and resistance to immunotherapy. And finally, identify the differentially expressed protein associated with resistance to immunotherapy and mine these data to try to identify new novel therapeutic targets for patients who did not respond to immunotherapy or showing some sort of resistance. The significance and the future steps of this project. First, this project hopefully will help to better select patients with a higher chance to respond to immunotherapy, and this will eventually improve patient outcome and quality of life, and will have also impact on the public health sector by improving the cost effectiveness of using immunotherapy in this disease area. Using our innovative and integrative approach of using different or two independent cohort and validate the finding will mostly result in a high potential to clinically translate this finding to that in a short time. Through our French collaboration, who are involved in several phase 2 and 3 clinical trials, there is a big chance that we can validate the result of this project in one of these clinical trials, and this will fulfill future regulatory requirements to translate this result to the clinic. Finally, this project mostly will be a foundation for several prospective clinical trials to establish a new standard in the malignant mesothelioma management. Cure Cancer funding is critically important for this project and to me. So through this funding, we will be able to complete this project, which is a first step to establish the foundation of proteomic-based biomarker for immunotherapy. As an early career researcher, this funding is critically important to my career as a cancer proteomic researcher and to improve my chances to get my own team in the near future, hopefully. And as I mentioned, the successful completion of this project will allow further comprehensive research and collaboration to validate the finding, which will be a fundamental step in translating the results to the clinic. So yeah, this was a very brief summary about my project. Happy to take any questions.